various kinds. I'm a psychiatrist and anthropologist, and my work is mostly in China. In fact, it's been said of me that Kleinman sees the world through the eyes of the Chinese. And so I tend to be a little bit stilted in my presentations, but I'm trying to include South Asia into this as well. And the reason this is a useful time for me is that Vikram Patel, Lincoln Chen, Michael Phillips, and I are doing a China-India comparison for the Lancet in mental health. So I'm thinking about this topic. But let me just introduce it this way. Is that sufficient as an introduction? I mean, I could go on. I could introduce Dr. Leaning over an hour. But I think that you'll accept just enormous admiration for her. Now, let me just say this: there are two things to keep in mind about mental health globally. And one, that if we look at mental health as a share of the global burden of disease, following the work of Chris Murray and Alan Lopez, which introduced a quality of life measure, DALYs, to supplement mortality as a way of seeing the burden of disease and to configure it, of course, economically as we configure burden, but with some sensitivity to individual issues. That mental health across the world accounts for somewhere between 7 and 20% of the global burden of disease. Lower in low-income nations, higher in high-income nations. So most low-income nations have a global burden somewhere between 6.5% and 8.5% of the global burden of disease. Middle-income nations like China and India have a burden somewhere between 12 and 15% of global burden of disease. And wealthy nations like ourselves have a burden of about 20%. And the second thing to recognize is the treatment gap. And that's why we're having this, I'm assuming, talk, because the treatment gap is very large. So in most countries around the world, excluding high-income countries with big mental health systems, 75% on average of individuals with depression, anxiety, even psychotic disorders never receive treatment from a qualified health or mental health practitioner. They may receive traditional treatments, of course, but we have no evidence in the mental health field for serious disorders like serious depression or psychosis that traditional treatments really are effective in this area. They may be effective for milder problems. So the big issue is lack of access. And we can say some other things, that if we look at depression itself, and we take the major countries of Asia, of East, South Asia and Southeast Asia, and if we leave out Japan, which is a special case because it has the most advanced mental health system, then about 90% of people with depression do not access mental health services. And we can say, as I just said, 2/3 of patients with psychosis, somewhere between 2/3 and 3/4, do not access mental health services. And what makes China and India interesting, and there are many things, are that women loom large in this way, in some ways differently than in other parts of the world. So in Europe and America, suicide is a problem of men primarily, completed suicides. We have about 30,000 completed suicides a year in the United States. In China and India, suicide is a problem more of women than men. And in China, where I have myself worked on suicide, we've had a period of time 10 years ago when there were 250,000 suicides a year in China, which is a very substantial number of suicides. So 30,000 in the United States. Now China is 1.3 billion, and the United States 300 million. So we could say that 250 to 30, we would expect the Chinese to have a higher rate than 30, but not 250,000. But that rate, amazingly, has come down, and I'll talk about that, in the last 10 years. Very interesting. And we know that rural-urban migrations, which are important in both South Asia and in East Asia, are stressful for people. Now, we know some things that contribute to global health problems. Breakdown in traditional filiality and moral commitments put great pressure on the elderly. So the elderly in the mental health area is a very important concern. For example, 20 years ago, when my former student Lawrence Cohn, who is the head of the South Asia program at Berkeley now, when he did his research on dementia in India, he discovered that clinicians hardly used the term dementia, and families did not recognize, by and large, cognitive decline, but only when dementia became a personality problem. But this has all changed in the last 20 years. So dementia is a problem, a serious problem in China and in India. Actually, it's the most serious problem, just to make this broadly Asian, of all the Asian countries, in Japan, because Japan in 10 years will be the first country ever known in which 40% of the population will be elderly. I've got to be a little careful on this. Technically, demographers use age 60 as entering the elderly period, but since I'm 72, I think this is a gross mistake. But nonetheless, we'll stick to that figure. And if we stick to that figure, 40% of Japanese 10 years from now will be over 60 years of age. And you can just think that out. Japan today has 100,000 people who are 100 years of age. So I'm not saying, by the way, that they're all having problems, but the older you get, the more problems there are. And also, these regions have traditionally been associated with inadequate mental health services, inadequate mental health care financing, and very strong stigma associated with mental health problems. I want to come back to that in just a minute. But stigma is broad. So in the United States, even, the New York Times reported that for mental illness, as recently as 2006, that stigma was the #1 problem. And one of the questions we could raise here, thinking of mental health, is social stigma of the mentally ill a global human rights issue? No. Jennifer is an expert on global human rights, and one of the questions that I would ask, and not being an expert on global human rights, but being an expert on mental health, is the social stigma of the mentally ill a human rights issue? Does it benefit from being considered a human rights issue, especially in areas of the world like Asia, where it has such tremendous stigma? And here are the points I would make just in this line. Human rights framework is most often invoked to protect those suffering from things like political violence, not usually associated, we don't usually think of it with mental illness. But mental illness and the stigma associated with it do have major consequences for human rights. And stigmatization of the mentally ill plays a key role in legitimating and normalizing violence against people associated with mental illness, which is quite common in Asia. So not just in India and China, but all over the world, the status of the mentally ill is to be stigmatized, marginalized, and to have their human rights brought into question. Families and social networks of people with serious mental illness become increasingly burdened socially and financially by caring for and supporting individuals suffering from mental illness. And a complex lack of mental health interventions in many countries leaves families unprepared to care for the mentally ill and increases the stigma and increases the terrible things that happen to the mentally ill. Like, for example, in both China and India, you find, as I found in China and as my colleague Vikram Patel finds in India, you find many families will chain family members with mental illness, will chain them to a bed or to a doorpost or something. This is not done to hurt them. This was done to protect them, but it has a very negative effect in many ways. It dehumanizes them. It allows them to be treated like infants. It removes their rights, certainly. I think I'm just going to skip this for a bit. Now, stigma is an issue in itself. For the mentally ill, at least on the Chinese side, I would tend to say that the term is a euphemism for the degree of isolation and marginalization of the mentally ill. And the real term that should be used is social death, okay? And social death is the exclusion of a stigmatized individual or group from social life altogether in an effort to preserve what matters to the excluders, that is, to the group. Not because they're bad people, but because they determine that the mentally ill cannot participate in such things as rural gift-giving in villages, let's say, which are crucial to the participating in banquets and funerals. And by excluding them, they create the fact that they're socially dead. In the work of my former student, Yen Yun Chang, for example, in his wonderful book, The Flow of Gifts, he shows that the chronically mentally ill in Shajia village in North China were called dead doors, sumang, because your social connection should open doors. They couldn't open any doors, so they were seen as ineffective socially, and therefore were not given gifts, were not expected to be gift givers, were taken out entirely of the arrangement of social life. And you have, as you can see in the book Deep China, which I did with some of my former students a few years ago, that basically this ends up with women and men being considered who have mental illness, serious mental illness like psychosis, being considered socially worthless and inhuman, even inhuman. I'll give you an example. You may think I'm being extreme, but I'm actually being very conservative what I'm saying. When my former student Wu Fei did his outstanding study of suicide in a district of Hebei in China, he discovered when he was asking about what counts as a suicide that they didn't count the mentally ill who committed suicide as suicides. Because, as they said, you have to be fully human to commit suicide. And the mentally ill were not seen as fully human in this regard. Therefore, they were not counted in the official statistics for suicide. Really troubling. So the idea that there is a moral defect, that families lose face, and that the mentally ill themselves are socially dead leads to stigma that extends all the way from the general population to the families of the mentally ill themselves and to the mental health system. So that Sing Lee and I have shown that unfair treatment of family members is very prominent in the mental health care system itself and associated with stigma from nurses and from doctors. Seems unbelievable, but true. And also families. Now a number of studies, not just the one I cite here, show that families very efficiently convey stigma to their family members who have mental illness. So that's social death. I think I spent enough time on that. And then, so this issue, I'm raising this issue for Jennifer. Is it a human rights? And how would we combat it? So let me now just sort of turn to just very quickly say some things about women, but I know that Jennifer's going to say, have the most to say on this score. This is about women. So first of all, is this, what are the disorders that women seem to be particularly vulnerable to, and we in South Asia and in China, and we see that these include depression, where there's often a higher rate among women than men, and one of the consequences of depression is in fact suicide. It's not the only contributor to depression, but it's one of them. The second thing is that we see associated with women violence and its consequences. So if you go to Veena Das and Jishnu Das and others that have done a study in a slum in Delhi, which shows that that women who are labeled as mentally ill and who themselves have serious symptoms are frequently the object of violence, and the system they have access to is a troubling system. So I think we have the best data from India here, not from China, but I'm sure China is not so dissimilar. Okay, but the evidence we have from Jishnu and Das and from Veena Das is that surrounding slums in Delhi and Bombay are what can only be called predatory systems of healthcare providers. These are healthcare providers actually who many of them are not really physicians or nurses. They're businessmen. And for example, in Rajasthan, they have a group of businessmen who treat the sick, including the mentally ill, who are called Bengali doctors, because they come from the south. They all don't really come from Bengal. But what characterizes them is none of them have medical degrees, okay? So they become sort of the arm of the pharmaceutical industry that extends out into the community from the drug representative to the people through these, I don't know what to call them, pseudo-doctors, I guess, in some ways. And in this study that they did, which actually the most troubling part of the study was not even the mental health side, but was the health generally. They showed that there were infants in these slums in Delhi that had never been off an antibiotic for a single day of their life. They had received antibiotics all the time, though different antibiotics. So you almost were sure that they would have things like resistance to infectious diseases, serious ones like tuberculosis, et cetera. Just terrible medical practices that actually account for a significant portion of the income of people. So you have people not only spending money because the public health system is so poor on a private system that's dangerous, but actually that system does bad things to people in terms of the inappropriate and dangerous medical care. You'll find some of the same things as China. Now, China is ahead of India with regard to mental health care reform. And one of the great things that's happened in the last 3 or 4 years is that under a wonderful minister of health, Chen Zhu, who was the first minister of health of China to be a scientist, has a PhD in biochemistry from University of Paris. China has reformed its healthcare system, and it's reforming its mental health care system very, very rapidly, and improved its financing even in rural areas, So the things are changing very, very quickly. But whenever you see data on this subject, you should be very careful to interrogate it. So for example, we're interested in access of women to mental health services. My first question is, what are the mental health services? Who are the people in those services? I just told you there's a whole system that's unregulated and predatory that doesn't even appear in the public health picture, but is a dangerous one. But look in the system itself. So China lists about 30,000 psychiatrists, okay? I can tell you, nonsense, total nonsense, all right? China has about maybe 1,000, maybe 2,000 fully trained psychiatrists. But the other doctors are doctors who practice in mental health hospitals. But by and large, they're not trained. Sometimes they're quite good, but often they're not. So the real question for my mind, once we address access, is access to what? So this is a question put in two terms, volume and quality, okay? So the first issue is volume. And we want to obviously see a much better job done in volume. But the second question is incredibly important because it's access to what? To what kinds of treatments? So I want to give you just a personal sense of what it was access to when I first did my research in Taiwan and in China. So I began my mental health research in Taiwan in 1969 and my research in China in 1979. In 69 in Taiwan, you had public mental health hospitals that were kind of like American public mental health hospitals at that time. People got minimal treatment and often were allowed to vegetate into states of almost being asocial because there was so little stimulus. And you would occasionally get a medical assessment, but it wouldn't be a very developed one. But also at Taiwan at that time, you had a system that makes the predatory system I just described in India seem undeveloped, because you had a system in Taiwan in which hospitals were owned by families, and they were owned as family businesses, and no one in the family had a medical degree, okay, or a nursing degree. Okay? These were treated just like businesses. And you would have a hospital about the size of all the Asia-related centers on the first and second floor here. Half of the first and second floors are Asia-related centers, or this side forward. They would have, I don't know, 100, 150 patients in that space. Okay? Children mixed with men, children mixed with women, no separation of children and adults, women and men separated. Severe patients chained in rooms with a little hole in the ground where they could urinate and defecate, and with food literally given to them in the same way you would have given food to a dog, putting it on a plate and putting it on the floor. No utensils. Okay, well, in India, you're eating with your hand, but in China, you don't generally eat with your hand. No utensils. And the worst part about this was the political economy of it. So how did they treat the patients? All the patients were on inappropriate medications, like, for example, Valium, the equivalent of Valium at that time, for serious mental health problems. Why on Valium? Because as a business, they would buy a trainload of Valium, and then they'd have like 6 months to offload it, so everyone got Valium. That's what they got, okay? And once you were in a hospital like this, you couldn't get out. That is, it wasn't in their interest for you to be discharged, right? If you were a woman in a hospital like this, the stigma was so great of mental illness that even if you were discharged, generally you would be rejected by your families, even though they had a great deal of love for their daughters, because you would make all the other members of the sibship unmarriageable. And then to protect the rest of the sibs, they didn't want you. So if you didn't stay in the hospital, you would know where to go. You could be entirely normal after a while. Let's say you had an acute psychotic episode, became entirely normal. You spent your rest of your life in the hospital. Also, it was in the hospital's financial interest not to discharge you, okay? Since they made money off of you. I once got so upset about this, about a young girl, beautiful young girl, well-educated, who had bipolar disease and had come out of a manic episode and was doing very well was really perfectly normal, and that I offered to pay for her to leave the hospital. And that was not accepted by either by the family or by the hospital. So that was very bad. Now, if we look at China at that time, China simply didn't have hospitals. It had a few public hospitals, public mental health hospitals, and they were very large institutions organized around infantilizing patients. So patients came in, they were immediately had their head shaved, like prisoners do in China. They were put into the equivalent of prison uniforms, usually striped pants and blouses. And then they were, especially if they had a psychotic diagnosis, schizophrenia, and 90% of them inappropriately had the diagnosis of schizophrenia, but bipolar disease and others, they would be, well, let me just explain how they would be treated. So you'd have some visitors come in, could be Chinese visitors, might be foreign visitors. They were asked to sing and dance. So they sing and dance. But that singing and dancing was very infantilizing and dehumanizing. I once insisted to eat with the patients when I did my research in Changsha. I wanted to eat at the same table with the patients. And I was almost thrown out of the psychiatric hospital where this took place, because the doctors ate somewhere else and the patients ate by themselves. There was no mixing of staff in this regard. I could give you case after case that'll give you a sense of the horrors women experience in these settings. One example would be, there's a very well-known case in China of a young woman who was violent in the context of chronic schizophrenia, and who was repeatedly rehospitalized after episodes of violence with the family, and was finally killed by her sister to relieve the family of the burden of the illness. This is not uncommon. I mean, I'm not saying it's happening every day, but this is not an uncommon phenomenon of the mentally ill being killed. And in China, the main focus has been on mental illness as being a danger to society. So the whole idea is to protect society from the mentally ill. And therefore, the idea was not to rehabilitate the mentally ill. In fact, up until about 10 years ago, even though there were rehabilitation programs in Chinese mental hospitals, almost no one came out of them, because the idea was the best thing to do is to hold them in as long as you can and protect society. And every time there is a violent attack in China, and China has publicized a number of these against children and schools and the like, the emphasis is on whether the person who conducted the attack is mentally ill, and the assumption is that they're mentally ill. And this is a sign of the danger of the mentally ill. Now, in point of fact, if you look at mental illness in China, and you look at it in the United States, and you look at it in India and Africa, there is a slight increase in violence over normal populations, but it's a very modest increase in violence. Nothing that would justify treating all the mentally ill as if the major problem they presented was violence to society. So the Chinese perspective is safety from society, for society, number one. And I guess the last point I want to make is how things are changing in China. And maybe we're going to hear about on the South Asia side how they may be changing there as well. But let me give you some examples of big changes in China. So 10 years ago, I said there were 250,000 suicides in China, most of them by women, 3 times as many suicides by women in rural areas than in urban areas. The assumption was that all these women wanted to kill themselves. Researchers began to wonder whether this was actually the case or not, because nobody knew the relative prevalence of suicide attempts versus completed suicides. In the United States, we get about 1 million suicide attempts for 30,000 completed suicides. Most completed suicides are men, but by far most suicide attempts are women in the United States. However, what we've learned is that many of the suicide attempts are cries for help or expressions of resistance or anger, impulsive anger in settings. We had no idea what the situation was in China, but the method in rural China was extraordinarily lethal. So it was to drink a small bottle of insecticide, which was heavily concentrated. If you were not taken to a hospital within an hour, you began to suffer kidney failure, neurological consequences, and would die within a day from the insecticide. Most rural Chinese women did not live so close to hospitals. And the local aid station didn't have the abilities at that stage to do anything about this. So here, Jennifer Leaning is from School of Public Health, and this is a very good example of a public health intervention. Decision was made to change the containers and the lids on the containers so that they had a safety element, actually a stronger safety element that we have in the United States when we don't want children to open a medicine bottle, so we make it a little difficult. This made it very difficult to open up the bottle, okay? It's associated with a dramatic decline in the number of women's deaths from suicide in rural China, suggesting that in rural China, not unlike the United States, many of these were attempts not necessarily meant to kill oneself, but to bring attention to being poorly treated in a family, being under great pressure, which is in the setting of where men have moved from rural areas to urban areas. Just think of a young wife, responsibility for the farming, responsibility for the care of the young child, and often in rural China it's more than one child, and responsibility for care of the husband's elderly parents. Okay? That's a tremendous amount of pressure on people in that setting. The other development that's remarkable in China that I want to mention is, and here's one that shows you that all of us who do research should be incredibly careful about predicting anything. I devoted my whole career to doing research on mental illness in China. I predicted that China would never in my lifetime have psychotherapy as a significant part of what the mental health system provided. I couldn't have been more wrong than this prediction. China today is in the middle of what's called a Xinli Ru, or a psycho boom, a boom in psychotherapy. You have not just psychotherapy, even more unbelievable in the sense you have psychoanalysis as a leading interest amongst mental health professionals, psychologists, psychiatrists, the new breed of social workers, many people in society. Most of the therapists are women, again, suggesting increased sensitivity toward women's issues, and bringing a complement of psychological interventions to the use of medication, which had been the standard way of treatment. So now, if you go to the major cities in China, Shanghai, Beijing, you would see the same treatment at the Shanghai Mental Health Center, at the Shanghai Weisheng Jingshen Zhengxing. You'd see the same treatment there that you would get at the Massachusetts General Hospital or McLean Hospital. Same treatment. 30 years ago, you would have seen a treatment in which a psychotic patient walked into the Shanghai Mental Health Center. A big aide came over, knocked him to the floor. Two other aides held that psychotic patient down, and while the psychotic patient being held to the floor, electrodes were affixed to his or her head, and they were shocked. They were given 125 volts, and that was it. No permission was taken. No diagnosis was made. It was just coming in disruptive in some way or delusional, hallucinating, and they were immediately treated in this way. That's gone. That's the past. So in conclusion, and turning things over to someone who really knows something about women, mental health has gone through an incredible development in our time around the world. And we now have available intervention packages, such as particularly the treatment of depression and anxiety in primary and secondary care settings. It's particularly, where we're particularly effective. We have all the evidence. We have more evidence for the effectiveness of treating depression in primary care settings than we had when Jim Kim started the 3x5 program for AIDS in Africa. Okay? And yet, we have all these packages, we have all these developments, but I could be wrong on this, but I don't think I am. I don't think there is a single mental health program anywhere in the world, in middle income and low income countries, that has ever been generalized, ever been brought to scale. So all these programs that we have are demonstration projects in a region, in a city, in a portion of a city, but they're never extended to a large area. Well, my final words are that in April of 2015, the World Bank will hold a meeting for funders in the mental health area that explicitly will aim at developing the support needed for programs to be widely developed in particularly in low-income societies, but also in middle-income societies that have problems with investment in their system. So just so that last point makes sense to you, I told you that the burden of disease accounted for by mental health problems is between 7 and 20% worldwide, depending on the economic level of the country. But for middle income and low income countries, 2% of less of general health expenditure is targeted at the mental health field. So there's a gap, also a big gap on the funding, and that's what I'm hoping the World Bank's entry into this area will affect. And right at the leading edge of this, I would say, right at the leading edge of this are China and India, of the best examples of developing interventions. So in India, it's Vikram Patel in Goa, Mohan Isaac who's now in Australia, but was at Nimhans in Bangalore, and a variety of other people in Chennai and other places who've developed these remarkably interesting programs that are just waiting to be generalized. And in China, we have exactly the same kinds of things waiting to be generalized. So my swan song to this field is going to be bringing funding to it of an adequate kind. That's what I see. If I had to say right now, what's the big issue? What would be the biggest issue for women and for men in India and China? It is really bringing funding to programs so that programs can be generalized in primary and secondary, so we can integrate mental health for the treatment of depression and anxiety in primary and secondary care settings. And that funding will make it possible. Okay. Yeah.
Well, thank you. So Professor Kleinman is, as you know, an authority on a number of different issues. Definitely China and India. And without question around the world, one of the foremost thinkers on mental health issues. Through a clinical lens, also through a public health lens, as you hear, speaking at population scale, and then also on a more nuanced, but because he knows a great deal, that lens or level of invoking cultural differences, which, as well as gender differences, which are very alive when one's talking about mental health. I was asked to talk in large measure because I'm beginning to work with colleagues in the South Asia Institute, as well as in the Brigham and the School of Public Health, on a project in Karachi, Pakistan, where the estimated burden of mental health illness for the city of 18 million, it's a city of 18 million and growing, in a country of 170 million, where the estimated burden of mental health is approaching, it is 48%. And
Wow.
it's very high, yeah. Now, I have not kicked the tires on the data, which is a point that Arthur mentioned, which is a very important point. Any of these estimates are subject to scrutiny, and something as sharp as 48% makes you wonder on what basis. They're usually generalizations from moderately small scale sample size, and usually, well, certainly in the setting of Pakistan, it is community-based family interview. But then you hit a certain problem when you're trying to get that information. If you are going into a household and you're asking any range of questions about mental illness, mental distress, who's in the room as you answer? Is the husband answering for everybody? Do you get the sort of senior woman in the group by herself to talk? So all of this data actually can wind up being useful, but from a standpoint of really understanding what's going on in a place, you've got to think about it as being a hunch rather than a hard planning number. But when you put this against the other numbers that Arthur Kleinman was talking about, where it's between 28 and 35%, et cetera, or lower in the lower income countries, 6 to 9% or something, Karachi is poor. And the estimated level at 48% is really striking. Okay, that is not broken down by gender. And there are two very important aspects of Karachi that you should bear in mind when we're thinking about what to do with this issue. One is that Karachi is in a chronic state of desperation. The levels of anxiety, and it flows into the mental health measure, but the levels of anxiety that anyone who is working, either as a mental health worker or as a physician or as a nurse or in the school system, anyone who's in social services, interacting with the general population, will say that the level of anxiety is almost intolerable, that it is an astonishing aspect of a feature of any interaction you have with rural people who've come to Karachi out of desperation because of a number of things we can talk about, or the urban population that has been there for 10, 15, 20 years. Karachi, in many ways, is a city of migrants. It was a bustling and big city pre-partition. A number of people left the city to go back to India during partition, so Hindu-affiliated residents went back to India, hundreds of thousands of them. But reciprocally, tens of thousands came from India to go to Karachi. The majority of the Muslim population in India went to the Punjab and northern parts of Pakistan, but a number came in. However, there's been high fertility rate and growth rate from in-migration in the years that have followed. And in the last 10 or 15 years, with growing impoverishment of Pakistan generally, the high level of terror that's being experienced in the northwest provinces and the tribal areas, quite clearly linked to the war with Afghanistan, has resulted in many people who can make the move. And they do it somewhat in a saltatory fashion, that they'll go somewhere and then they'll move down south further and then they'll get their way down to Karachi. It's not a simple trip. The roads take a phenomenally impossible time. The railways do exist and they go, but it can be a 36-hour trip from Lahore to Karachi just because it stops, breaks down, etc. The railroad line is not good. But people are coming in. It's a city of people who are fleeing their own country. Karachi has, over the last 20 years, become a beacon of international attention as a city rife with crime, corruption, heavy, violent road traffic, and a increasing level of terrorist-related bombings, kidnappings, and killings. In the last 6 months, Karachi has had 1,700 bombs go off in the neighborhood. So that's 1, 2, 3, 4 times a week. No, I'm sorry, that it's been 1 to 2, 3 times a week, so whatever that is in 6 months. But they've had 1,700 serious casualties brought to healthcare. And Karachi, therefore, has one of the most sustained experiences of dealing with bomb casualties of any city in the world. And these bombs they go off in apparent to the general population, apparently random locations. And so one aspect of the anxiety that people are feeling is that you are never quite sure where it's going to happen and what place you are in that might be near a target area. The other aspect of this is that the area the city has the bomb then becomes deeply disturbed for the 6 to 8 hours it takes to figure out what's going on, stop the traffic, move the ambulances in, take casualties out, so that the city is not a tranquil place, to put it, to underestimate it. The issue of bureaucracy and jurisdiction, which Arthur Kleinman brought up through the funding mechanisms, but also the fact that the facilities are very uneven and it's usually of relatively low quality, isn't a live one in Pakistan. There's a central government, there are state governments, there are district governments, there are city governments, and then there are neighborhood, smaller governments that are given a certain amount of autonomy, but generally anything sweeping you want to do on a scale-up mode has to be negotiated up through a number of levels. And because of the insecurity and the political culture in Pakistan, anything of major significance that would involve large numbers of people or large amount of funding has to go through the central government. And that is, in terms of distance and communications, very, very far away from Karachi. So the city has begun in the last 5, 6 years to come together, not yet completely, but to come together in parts of the city, regions of the city that are most affected, to say, what are we going to do about these two big issues? The level of trauma, and then therefore trauma care that's required, and the mental health of our population that is perceptibly fraying at the seam. And one of the collaborations that the SAI is working on related to this issue is with the Aman Foundation, which is a foundation in Karachi. Very wealthy family has decided it is going to, from Karachi, has decided it's going to put its entire fortune into issues around healthcare and education and work training in the city of Karachi, which, if you think about mental health on a population scale, having children in school where they actually feel safe and are educated is a terribly important support to their own stability and to the families that send them there. Whew. Kids learning, he or she's over there, they get a midday meal, the teachers are reasonable. I mean, that is a relief, not on the street. There are aspects of adult education that are being dreamed about because many of the women in particular have very poor educations, having fled from violent areas and arriving as immigrants. And women in Southeast Asia tend to have, well, certainly in South Asia, tend to have much lower rates of completing secondary school than boys. In India, and to some extent on paper in Pakistan, completing primary school looks fairly equal by gender. But then it diminishes greatly when you look at secondary school leavers, and it's a tiny percentage of women that get into university level in India and in Pakistan. We asked about the madrasas that are well known and understood as a phenomenon in Pakistan in terms of education, and the askance with which the liberal West looks at a notion of a madrasa as a school where boys go and get inculcated in the Quran and come out actually quite radicalized, is not shared that much by people who are deeply involved in social service in Karachi. The schools do teach other things. There's some schools that are actually quite rabid in the sense of radicalization, but a number of them have a better education and grounding and instill some discipline and should not entirely be painted with a negative brush. But there are very few schools for girls, and girls are often used in these very poor situations as part of the working family. In an urban setting, it's a little more complicated and more threatening to their well-being, but that's the reality of it. Coming into the mental health aspect, I picture this: the women in a very conservative Muslim society are kept at home, and the girls, when they're young and with their brothers, can go to school. But as they get older, it gets harder for them to go outside on their own. And that's one reason why schooling is not so prevalent among peri-adolescent and adolescent girls. There's very, very strong codes about not going out by yourself, even appropriately veiled. You need to be with other people. And the women in the household, the adult women, have very circumscribed lives. They will go in about a block in one way, 2 blocks in another, and a third block in order to get food. There are other things they do. They will go to the market, the nearest market. That's the only socializing event that they can appropriately and perhaps safely do, although markets are big targets for bombs, which is why parts of their daily activities are so intensely troubled by the risk of the fear of bombs. They will go and get their hair done if they have any extra pin money. So the hairdresser is another place. And then at the market, the stalls that are selling scarves and saris, very cheap saris, but still ones where, and other forms of dress, are ones that the women will be attracted to and cluster around. Now, why am I picking this up? Because the mental health strategy that is being developed, and we're working with people from Cambridge Health Alliance, which is the Harvard Teaching Hospital, but it's a public Harvard Teaching Hospital. It has a very robust mental health service dealing with poor people here. Well, also just regular people with insurance, but it has a mandate to take care of the poor. The model is one where we're thinking of 3 interrelated approaches. For a 200,000 area population, an area that encompasses 200,000 of the 18 million, so this is definitely in that sub-state situation that Arthur was talking about. It's a proof of concept. If it could be shown to be working, then of course there's the issue of how to scale it up. The plus here is that the Aman Foundation has a great deal of money, a great deal of influence in Karachi, and has the full support of the city health and mental health officials. So that is a positive. The idea is that the level of education is so low that one cannot really think of trained community health workers. That is, people who have a little bit of training in community mental health or in community health. They're just so few and far between. So the idea is to get women who have been identified as leaders in any other way in the community, who had perhaps volunteered in the school or who have a little bit of education, or an older woman who is known to be fairly outspoken, and people who have participated in group events at the mosque. So to find some people who have actually already shown an interest in interacting with a larger circle outside their family, and then to train them in community mental health interventions. And the main intervention that they will be training will be on a family-by-family basis, which is in a concept that is being used quite widely now called psychological first aid. So these non-mental health trained people, but who've had training for mental health people, will go out into the neighborhood, and they will then be training other people in what's called psychological first aid. And then those other people will go out to the actual homes and teach psychological first aid. So what are the elements of psychological first aid? It's essentially teaching people, even quite uneducated people who are not particularly used to thinking about how they're feeling, they are ways of reducing anxiety. They're ways of recognizing when you are feeling out of control. They're ways of interacting, having you have a check on your reactions and voice when you are interacting with others, when you're angry. It's pretty cognitive. This is, you're reaching people at a cognitive level of where they recognize when they are out of control. And then teaching them techniques about first recognizing it and then what to do about it. 5 deep breaths. Walk into another room. Look at the garden. I mean, these are going to be very culturally sensitive, but they do relate always to modes of getting outside yourself. So any view of nature you can get is good. Nature's hard to find in these slums in Karachi, but there are ways in which you could say, have flowers here, have a little garden here. Exercise is very hard for women to get, again, because they're so circumscribed by the mores. But going with a small group more than once to the market and back, going with your friend when you're feeling particularly lonely and distressed. Anyway, there's going to be a packet of psychological first aid measures that will be adapted for the people you see. They get used to it and trained to it. Then they will train the next round of people, and then that will arborize out into the community. And some of the people who are going to be trained in this psychological first aid will be hairdressers, dressmakers, people who are selling goods in the market, so that they themselves can calm down because they're out there and exposed to whatever the city brings it. But they can also then be helpful when they see one of their regular clients. And the city is vast, but it's intensely local, just because people, have to just sort of circle around in the same 4-block area. So everybody knows everybody. So if you begin this notion that it is okay, if you have a few clear ideas about what to do, it is okay to help someone. It's diffusing this notion of community support, which then helps break down the isolation and will then also begin to create more space for people to say what else is in their minds, what else they need, how else can they seek help. The other aspect of this intervention involves a very interesting pivot to the disaster service. The emergency physicians in the hospitals are moderately well trained, but then they get well trained just through experience, or at least they are able to cope with these 1,700 casualties every 6 months that come to the emergency departments, grievously injured by bombs. These are casualties, I don't know the death rate. But they are burning out. You can't keep an emergency physician or an emergency paramedic in the hospital on staff for more than a year and a half. They leave. It is too brutal, too unsuccessful, too terrifying, too depressing. And so they are leaving. And Pakistan doesn't have this kind of manpower pool to be losing expert people at the casualty level every year and a half. And so the notion of teaching them psychological first aid is very important. That's another target group. The isolated families, particularly the women in the general population, and then the disaster workers who are on staff at the hospital, the emergency casualty zone, which includes nurses, paramedics, doctors, and a whole range of other ancillary health personnel, ambulance systems, ambulance guys also. And health people often go in the ambulance, so it's the British model where you don't have non-doctors in the ambulances. Often the doctors are in the ambulances proceeding out. So they see the most horrifying aspects of these bomb casualties, not packaged by the paramedic and face cleaned off and wrapped on a stretcher and brought into the ED, which is what we have. So they get involved in extrication. And so the whole exposure to this brutality is turning out to be extraordinarily difficult for the doctors. Teaching them psychological first aid, and then teaching them how they can feel that they are making a difference even when a large number of their patients every day come in mutilated and despite efforts they die. I say a large number. Based on my experience in speaking with and knowing what a large number of emergency physicians have experienced over their careers, a day where you have 2 serious injuries coming in, casualties, car crashes, bombs. We're not that experienced in it. And you have a death associated with each one of those is really extraordinary. I mean, that week is very tough. It comes back to you 2 weeks later. The doctors at Brigham and Mass General in Boston City who were dealing with the Marathon bombing and some of the other smaller hospitals, I mean, they were going through their own acute stress disorder and PTSD. They still are in it if you ask them to go back. And that was one incident. So these doctors need, therefore, to be taught how to make sense of their lives and not to feel that they have failed when the patient dies. Their job is not to just care for the grievously injured. Their job is to care for the family. And so they have to be the caregiver for the family and help them grieve and cope with the death. In other words, that their efficacy is not shattered when the patient dies. Their efficacy is that they are to care for those who are surviving. And I mean, they're introducing this. I'm not making this up as I go along. They're asking for more help in scaling it up. And it's working. I mean, that you would think that the doctors would be so troubled and shut down. But in fact, they're very open to their colleagues and to skilled local people with some mental health training saying that here's how it should be done. And there's been a bit of an ascertainment going on this fall, and there's going to be a big meeting in January in Karachi where we pull together some findings to make the larger program go underway. And so this is psychological first aid training, caring for the caregiver, and then this links directly to what you were talking about. There's got to be better access for women to mental health services. At a certain point, they can do psychological first aid, but there is deep depression and anxiety and serious mental illness in this population. And so there is a plan to have a smaller scale outreach mental health clinics but also then modes of where the women can go without feeling stigmatized. And a notion is to have this be in group therapy. Again, this will allow people to see that they are not alone and then share in that mode. So it's going to be group-based mental health care with provision for these isolated women to get to this place, be safe, and be taken back in a mode that doesn't expose them to the street. I will be going. I haven't been. I'll be going to Karachi for the first time. And my experience in working with women in humanitarian crises, it prepares me to understand that what is being done here makes a great deal of sense. This is not a humanitarian crisis in the sense of all the disaster people speak about. the onset, the ramp up, the acute impact, and then the follow-up, knowing that psychological care afterwards is the most important issue when you are dealing with community response to disasters or crises. Even in a refugee setting, people have a new set of assaults when they're in a refugee camp, but at least they're not at the hot front of the conflict and they're not in flight. Here, these populations are living in incessant jeopardy. And so that I'm aware that the international models are not very good. We certainly have populations like that in the United States who are living in very violent parts of some of our cities, et cetera. So here, this is why we need very skilled community mental health people, say, that can be found here in the city, who say the only way to go in now is at a population scale, a group scale, and to try to have people adapt. The public health mode of prevention, of course, would suggest stop the bombs, isolate them, but that is not a given in this city at this time. The women also are, I didn't go into this with a great deal of discussion, but it was enough to sort of have 2 or 3 interactions with people to know that this is the case. There's a high level of domestic abuse in these families. The men are feeling the stress as well. And in the work and education training program that the Amen Foundation had set up for thousands of young boys, they had a drop-in mental health room. You just wanted to talk about something. And over a 3-month period, about half the kids would drop in, unique visits. And about 30 to 40% of the boys complained of sexual abuse. So that was surprising to everyone. The extent to which that's generalizable is impossible to know at the moment. So there are buried dynamics within the family or extended family infrastructure that are also contributing to, real taught issues around emotions and bonding and attachment and terror. At the moment, the Amen Foundation and the people they've brought in, Aga Khan is very involved in this too. It's a coalition of very wealthy and talented groups. They're dealing with the points I raised, that is, holding on to humanity and skills at the emergency and hospital level and keeping people in a situation in the households where they have some access to places where they can talk and find support and where they have some access to their own cognition and self-control if they're taught the techniques. So this goes to the microcosm of some aspect of South Asia. And I'm very glad that you provided the larger context.
It would be wonderful to have you come back here in a year and say what exactly on the ground you see. I left out a few things. Let me just mention. One is the indirect programs that have effect on women's mental health. And if you go to a book that I edited with Alex Cohn some years ago called Case Studies in Global Mental Health, we review a study, a very interesting study done in North India, of an anti-illiteracy campaign, which simply had the objective of raising the literacy level of women in villages in northern India up to a kind of primary school functionality where they could read the label on a medicine or read a bus direction or a street sign. And to their surprise, when they did the evaluation at the end, the women expressed a very substantial decrease in the depressed feelings they had. Quite impressive. And this fits in very nicely with some of the ideas that that Esther Duflo and Banerjee at MIT have about the poverty trap being related in some way to depression, because depression has associated with hopelessness, lack of energy, lack of ability to concentrate, et cetera, and so may actually play a role in making it more difficult for people to get out of poverty. And so the first thing I wanted to point to was that there are a number of indirect ways that mental health gets affected. And one of them, one simple one, is literacy. We already heard about schooling and some of the differentials in schooling by gender. And a second important set of programs are programs that are aimed at shanty towns and slums. Now, why is this important? And this may have some relevance to your Karachi experience. So in 1995, I directed a program called World Mental Health, which was released at the United Nations, a book from Oxford University Press, and our major respondent was the then head of the UN, Boutros Ghali. And then we had releases around the world, including in Delhi, which I'll have to tell you about some other time, but it was the most controversial release because I got attacked by the Indian press that we didn't have. We had about 4 Indian consultants, including one major consultant, but they felt we didn't have enough. It was my first experience with the Indian press, a very interesting experience. But that book shows that contrary to what epidemiologists show for diseases, that you can count the number of cases of depression or anxiety separately, that most mental health problems actually occur as comorbidities with each other and are very difficult to separate out. And that for shanty towns and slums, you get a clustering of mental health problems, which is it's completely unclear as to which came first and which came later. But the clusters read like this. You get a cluster that is depression, suicide, substance abuse, violence, both on the street and domestic violence, PTSD, all occurring together. So if you think of the significance of that from intervention standpoints, it challenges, when you have a cluster like that, it challenges the model of integrating depression into primary care or secondary care, because supposing you do integrate it effectively, A, would you get people from the slums there? And B, what good would it do given all the other problems that are occurring that would lead perhaps to recrudescence or a new case of depression? So the question is, how would you intervene in these clusters? How do you intervene? That's why I'm very interested in the kinds of things that you're talking about for Karachi, because I haven't seen anyone really come up with effective ideas for intervening in these clusters. But I think that if we're going to address mental health in various areas, that's very important. And the last point I want to make are tribal peoples. So if we look at ethnic minorities in China, there are something like 56 ethnic minorities, but actually China has many more than that, but they get lumped together to equal that number. They are the poorest people in China. They also have the highest rates of certain diseases like HIV/AIDS, and they have substantial mental health problems associated with often poverty and broken traditions. That is, their indigenous tradition is having trouble maintaining itself or is literally broken. And associated with that are are a cluster of problems that are substance abuse, sexually transmitted diseases, depression, suicide, violence. Now, we can see that, let's say, in Yunnan, in southwest China, among the ethnic minorities, the Dai, the Yi, all the different ethnic minorities. Virtually all of them have this pattern. But we can see this pattern in tribals in India. We can see it amongst Native Americans in the United States. American Indians have terrible, terrible mental health indices. Terrible. Approximating what we heard for Karachi, you know. Reservations where 50% of the people are alcoholic, where there's enormous violence, et cetera. And if you look at them, they also are broken traditions. In fact, one of my PhD students once worked with the Flatheads reservation in Montana, and when she spoke to them of what they thought was the problem, they said to her, well, you see, we're no longer the real Indians. The real Indians have all died. We're some other blend of Indians living in and out of American society without our traditions, without the language. You know, whatever we are, we're not the real Indians. It was a really terrible comment if you think about it. And I can tell you that the WHO has done a report on First Nation peoples all over the world, from Canada to Russia to Latin America. They're all in this condition, okay? So that's another thing, another aspect of this, that there's something about modernization, globalization, and the latest phase of political economy that we're in, sort of the neoliberal phase of capitalism, that has had a devastating effect on First Nation peoples, everywhere, without exception. Well, there is an exception, actually. A few of the casino-based Indian tribes in the United States have been able to sort of get themselves out of this picture, but there are very few exceptions. So that's another issue. But how would you deal with that? Here, you know, just providing mental health services, would that be enough? Well, in the United States, the Indian Health Service pours money and services in. It's not enough. Doesn't do the job. We have reservations that have some of the world's highest suicide rates. Huge rates, you know. The American rate is under 10 completed suicides per 100,000 population. We have reservations where the rate could be 500 per 100,000 population, 1,000 per 100,000 population. Huge rates. And so, I want to indicate that there are aspects of the mental health field that are more doable than others, and places that we really know a lot. We know a lot about depression in primary care. But about the last problem I just told you, First Nation peoples, I think we know all too little how you would remedy it, how you would respond to it in some way. And just think of the violence statistics we just heard. Well, I want to point to another kind of violence, which is domestic violence, and move away from since the rates are unclear in China and India today. But let's take a place where the rates are very clear. Latin America, we have very good epidemiology on Latin American rates for domestic violence, especially violence toward women. And what we know from Latin America is that in many Latin American societies, 50% of all women, married women, report serious domestic abuse. Half. And where the norm seems to be that on a weekend night, a man goes out, gets drunk, comes home, and beats the hell out of his wife. That's the norm. Okay? Now, I want to suggest that to a greater degree than we have ever thought, there is domestic violence in Chinese society. We have not looked at it. We've looked at it in the United States amongst Chinese Americans. It's just as high as in the rest of American society. Okay? For a long time hidden, very much hidden. We're just learning about this in China today, especially in rural China. But I would suggest that we're going to be surprised as we see the rates go up. I don't exactly know the rates in India, but I've been told by colleagues in India, they also suspect.
Yeah, that's what I'm hearing too, that it's
domestic rates are high.
It's a tip of the iceberg. We don't know it.
Yeah. So again, this is an enormously important area. Yeah.
Building on one thing that Arthur Kleinman just said, that this is a survey that was done recently, 2010-11, for all of Pakistan, looking at mental health and what the women were saying was most necessary. What did they want? And they definitely wanted access to mental health services, but the first thing they wanted was an income-generating job.
Yeah.
They wanted more money.
Right.
And this gets back to the point you're making about education and livelihoods. I mean, a lot of what is going on is the degraded empowerment, gross under-empowerment. They're helpless. They're caught for so many social and geographical reasons and economic reasons. So flowering up a bit, letting people raise their head and have a sense of, I am somebody, I can read a street sign. I think it's a universal issue, but it's very clear in this Pakistan data.
Let me ask you a question, Jennifer. What do you think of this idea of making the stigma that chronically mentally ill experience into a human rights issue?
I totally think it is a human rights issue. If you look at the right to health in the International Covenant on Economic, Social, and Cultural Issues, it is cultural rights. It's Article 12. It's very, very clear. It's quite long. And then General Comment Number 14 that has been adduced to that by UN experts as the article's been reviewed, basically stigmatizing people who have disabilities or who are ill is a violation of their human rights. There's just been a recent international covenant, widely signed. U.S. helped draft it, may wind up signing it. An international covenant on treatment of people with disabilities that is explicit about issues of stigma, and mental health is included as a disability if you're chronically mentally ill. And so the mainstreaming no stigma supports allowing place for people to be and work and find their own path. This is just a very, very powerful document. And if it were actually operationalized as opposed to being signed and ratified throughout the world, it would make an enormous difference. From my perspective, the main Western organization that has been at the forefront of dealing with the stigma of mental health has been the Open Society Foundations. They are just extraordinarily clear about the standing that people with mental health disabilities must have in a society. And they operated, George Soros really began his work in the areas that are now the former Soviet Union, under the cloud of the Soviet Union, and then since after, at the fall of the Berlin Wall. And they have, their focus has been on the treatment of the mentally ill in Eastern and Central Europe, which is appalling. Goes back to medieval days. The sorts of hospitals that you heard described in China are probably not much worse than what OSF was confronting when they moved around, Romania and Bucharest and capital cities in Moldova. And they're essentially speaking about these issues, mainstreaming, deinstitutionalizing, community places where people can live, adequate skills-based training that meets the people where they are, empowerment and sheltering them. So they are intimately familiar with this and speak to it always through a human rights lens. I don't think it is not rhetorically eccentric to speak of stigma applied to the mentally ill as a major human rights violation. I completely agree with you, it is.
I'm glad to hear that. Yeah. How about questions from the group? A lot of people here.
Yes, thank you. It was so interesting to talk, but very depressing. But I just wanted to ask on the figures about the incidence of mental health. This isn't my area at all. I mean, you were saying in high-income countries is 20%.
Is the global as a percentage of the global burden of disease?
Yes, and I was just want two things. I mean, how much is that because there is better knowledge about the incidence of that? But the other question is, are there any examples of whether you want to call them industrially advanced or high-income countries that don't seem to be experiencing that
level of, no.
Because if not,
I don't
projection for the future.
Yeah, I don't know if I'd be interested to hear if there is some work that would suggest there are some. I've never heard of it. It's an interesting thing. Why is it that if we take the United States as an example, if we look at the experience of the United States over the last 20 or 30 years, the fact that it is the world's largest economy and is the wealthiest country by, not by purchasing power parity, but by GDP, does not mean that we don't have severe dislocations and gaps between the poor and the rich. We have now a degree of social stratification we haven't had in the past. That's worsened as the country's gone on in the last 3 or 4 decades. So there's a danger when we think of rich societies, that we're thinking of rich people getting mentally ill, okay? Now, there certainly are some rich people who get mentally ill. But Vikram Patel and I published in the Bulletin of the World Health Organization an article, if you go back to around 2001, 2002, showing that the same evidence of socioeconomic determinants of mental health, which shows that in poor societies, as you go down the poverty ladder, the poorest people have the highest rates of mental illness. You see the same thing in rich societies, not just the United States, but Europe, that at every class level, you find higher rates of illness, including mental illnesses. So that's important to recognize. So that when we're talking about a society like American society, we're not just talking about the middle class, we're talking about poor people having high rates of mental illness. And that's why, this whole idea of social determinants, I think, is incredibly important. I don't know if you know Michael Marmot's work, but it's really fantastically interesting work. Because Marmot shows it's not just rich versus poor, it's actually as you go down the class ladder, at every level of the class ladder, rates of illness become greater. And other people have shown that as you go down the class ladder, rates of stress go up and rates of social support go down. So that's interesting as well. We see all these things interconnected in important ways. Now, is there an epidemiological illusion of poorer countries having less mental illness? Possibly, because I can tell you, using China as my example, and we have quadrupled the rate of mental illness in China over the last 30 years. And while there is some evidence that part of it is due to real change, a lot of it is counting. Okay? Now, the interesting thing about mental illness, by the way, also, is for those of you who are not too oriented to this, is that in poor societies and in rich societies around the world, of the 10 leading causes of disability measured by disability adjusted, or years lived with disability, or disability adjusted life years. But let's take the former, years lived with disability. Of the 10 leading causes, 5 are mental health problems. With depression is either number 1 or number 2, depending on where you look and how it's measured. So do you follow that? So that means that these are among the most disabling conditions. They count for high rate, and if you put them all together, remember I said that in rich societies they account for near 20% of the global burden of disease. Poor societies closer to 6 to 9%. If you put them all together and you look at rich societies, they're the largest category of disability. Okay, they're the largest category of disability. So that's what makes the gap in funding so interesting. That in spite of them being such a huge set of problems, economically burdensome in every way you can measure, they have the least amount of money directed to them. So how do you understand that? So let me just say that I know this may sound shocking to some of you, and it's shocking for me to propose, but I think there's some element of truth in it. I think the stigma extends into health policy. Okay.
Well, just,
What do you think about that?
yeah, there's my assistant just got this WHO packet about their appeal for aid for the victims of the floods in Pakistan. There's another big set of floods in Pakistan now that started in August and are continue to linger, and Karachi's downstream, so it gets the water as it floods out. So it's a low level of flooding, but it still is impossible to live, you know, if you've got 6 inches coming into your hut and stuff. And so you remember there was a very big flood in 2010, the Indus River floods, that displaced 20 million people. 20 million people displaced from their homes, and they were displaced for well over a year, some of them, because the waters hadn't receded, they were stranded on islands, the land had disappeared, landlords had taken it, huge issues of land tenure in these floods. In any case, these are bad. 6 million people are displaced. And if you look, which of course is a temporary refugee problem, but if you look, this is within the health cluster requirement for the World Health Organization. They're asking now for 56.2 million to help with the flood-affected victims. If you go down that list, there is something called psychosocial and mental health, and that's 500,000 out of 56.2 million. And the failure of the humanitarian community, you know, they have vaccination, water quality testing, ambulances and vehicles, so you can know there are going to be more, you know, white Toyota Land Cruisers all over that part of Pakistan. But if you think about what some of these inputs are and how they could have been reframed so that there was an attention to mental health at all levels, you could have had psychosocial interventions that were packaged towards education, mothers taking care of babies, you know, bringing communities together to figure out what they're going to do about their next term of a few months in planning. All of that would count as community mental health and psychosocial intervention. But it gets bucketed into these extremely stringent and dry categories, so that all of this money, it reflects they're not thinking that this whole thing should be conceived of as a psychosocial intervention. Yes, you're saving lives, but 2,000 people have died in these floods already. Now they're going in to deal with the people, the 6 million displaced, and their health needs. Well, you can bet that one of the major issues that is going on in the minds of these surviving Pakistani families will be, what do I do next? Sense of hopelessness, deracination, fear for their lives because it's a disordered settlement they're in, you know, bandits that are out. And all of that could be addressed if you had a different lens on it.
Great. Well, I know I have to get to another lecture, so let me thank you all for coming, and thank
you.
Jennifer for such a wonderful presentation. And
Pleasure to do this with you. Thank you.